Morning, everyone. Thank you for your invitation. It's not easy to speak about proteinuria in a few minutes, but I will try to resume to give you some practical message. So with GFR 125 ml per minute, both kidney produce about 180 liters per day, which contain about 10 kilograms of protein. But fortunately, less than 0.01% or 1 gram of protein pass through the glomerular filtration barrier. The total urinary protein excretion per day, the normal value less than 150 milligram per day, and in pregnant 300 milligram per day. As you know, the increased albuminuria is an early marker of kidney injury in diabetes, hypertension, glomerular disease, and is a biomarker of cardiovascular disease risk. The early detection is important to do early intervention to delay and slow the progression of chronic kidney disease. So what's the types of proteinuria? We have 4 basic types of proteinuria. The first, glomerular proteinuria, that means increase of the permeability to protein like primary disease, minimal change disease, or secondary like diabetes. Tubular proteinuria like tubulointerstitial nephritis or drug toxicity. Overflow proteinuria due to the increasing of production of low molecular weight protein like multiple myeloma. And post-renal proteinuria is any inflammation in urinary tract infection, tumor, nephrolithiasis, etc. I resume it here. See? To detect and measure the proteinuria, we have a semi-quantitative measurement like urine dipstick, which you use every day. But we have some false positive. And as you know, this method is insensitive to non-albumin proteinuria, like light chain. False positive, you can see it after using radio contrast agent and when pH of urine more than 8 and in the presence of gross hematuria. And just as known false negative, when the urine is too much diluted, this test may be negative. So it's advised when you have a patient perform a CT scan with contrast to wait at least 24 hours before doing urine analysis. To confirm proteinuria, we have 2 methods. The first is 24-hour urine collection, which is the gold standard. The normal value less than 150 milligram per day, and as we said for the pregnant, 300 milligram. The adequacy, it's easy to check the adequacy of collection by measurement the urinary excretion of creatinine and compare it with the expected value. The protein creatinine ratio or albumin creatinine ratio on a random or first morning urine sample is a practical alternative to 24-hour urine collection recommended by KDIGO. So what's the best way? We published it in 2011 in Lyon, a small study in 124 patients, and we do the measurement of urinary albumin concentration in the rest and after 1.5 hour of activity, and we compared all the results with the 24-hour urine collection. And we see if indeed that the urine albumin concentration increased with physical activities. So we have always to do the correction with the creatininuria and calculate albumin creatinine ratio. KDIGO recommend that the microalbuminuria should no longer be used by laboratories, but we still see this term until now. Now we speak about moderated increased albuminuria or severely increased albuminuria when albumin creatinine ratio, for example, between 30 to 300 milligram per gram. That means moderately increased albuminuria, and severely when it's more than 300 milligram per gram. So the assessment of urinary protein excretion of proteinuria. You know, when you have protein in the urine, that means may have benign or very serious problem of kidney function. So we have to distinguish between these two situations. by complete physical examination and medical history, and requested urine analysis with sediment examination. So, for example, when we have urine analysis positive, by physical examination and medical history, you have to check if the patient has diabetes, hypertension, malignancy, or autoimmune disease, or presence of hematuria, I mean microscopic hematuria. If it's positive, so the medical management will be according to the diagnosis, so diabetic nephropathy or lupus nephritis, etc. So if it's negative and patient has nothing on physical examination, medical history is negative, we'll repeat again urine analysis. If it's positive, that means the patient has persistent proteinuria. If it's negative, that means it's related to transient proteinuria. Usually it's proteinuria less than 1 gram per day, and sometimes related or associated to urinary tract infection or fever or physical activities in the patient. So in case of persistent proteinuria, that means we do urine analysis, it's positive, we repeat it, still positive. That means patient has a persistent proteinuria. So we have to confirm this proteinuria by quantification measurement. So if it's more than 3 grams per day, that means we are speaking about nephrotic range proteinuria. So patient need to be evaluated by nephrologist with kidney biopsy. If the proteinuria less than 3 grams, that we can do urine protein electrophoresis. If it's mostly albumin, we have also to do the kidney biopsy and refer the patient to nephrologist. If it's mostly albumin urea, so we have to check monoclonal light chain and evaluate the patient for multiple myeloma. If it's negative also, that means it may be related to tubular interstitial nephritis disease, drug toxicity, or others. So what's the role of kidney biopsy in this case? So we do the kidney biopsy in general, I will resume or simplify these things. If the patient has nephrotic range proteinuria, or in non-nephrotic range proteinuria, if the patient has active urine sediment, that means hematuria or casts, or we have the abnormality of kidney function and the GFR decrease. In isolated non-nephrotic proteinuria of 2 grams, also we can do it, but it's not really usual if the proteinuria less than 1 gram, just in some special cases. What does that mean, isolated non-nephrotic proteinuria? That means patient didn't have any diabetes, hypertension, any autoimmune disease, and no hematuria, no active urinary sediment. So, talking about the prognosis, you know, albuminuria is independent significant factor for chronic kidney disease progression and cardiovascular disease. So when you have increased albuminuria, that means we have poor kidney outcomes in the future. This is the KDIGO guidelines. As you see here, the green color related to the low risk and red color very high risk. When the proteinuria, for example, severely increased proteinuria when albumin creatinine ratio more than 300 milligram per gram, that means we have a very significant increasing of the risk of progression of chronic kidney disease. I like this slide, and it's really practical for everyone. As you see, we have some hyperfiltration states in diabetes, obesity, high protein diet, anemia, and pregnancy. That means bodybuilding trainer who took a lot of supplements, they came always with hyperfiltration. So in the future, we can expect that we'll have kidney injury, especially focal segmental glomerulosclerosis. In pregnancy, also, we have this hyperfiltration state. When we have this hyperfiltration, we'll have increasing in pressure, antiglomerular blood pressure. So we have increasing of proteinuria and increasing of glomerular cell injury, which will lead to fibrosis and focal segmental glomerulosclerosis. When you have focal segmental glomerulosclerosis, you will lose nephrons. So we'll have reduction in the number of nephrons. That means the other nephron will function more, and we'll have another hyperfiltration, which increase again proteinuria. So what my message from this slide, I just want to tell you, don't treat diabetes, don't treat hypertension, treat your patient. That means if he has obesity, he has to do lifestyle modification, reduce his weight, treat the anemia. I think if you have a lot of diabetic patients, you will see that some of them on anti-proteinic treatment, but when they start to have anemia, this proteinuria increased. You can check it and you'll find it's increased. You treat the anemia, his proteinuria will improve. And my home message always, referral the patient nephrologist. All patients who has proteinuria more than 500 milligram per day or 300 milligram per day of albumin, you should refer to nephrologist. We saw a lot of patients with lupus, with multiple myeloma, with really albuminuria in the beginning, and it's important to do early intervention to protect this patient and to slow the progression of kidney function. Thank you.